Hello everyone, now we'll be starting with the section 9 of your Apurba Sastry Essentials of Microbiology, which is regarding central nervous system infections. In this section, we'll be covering chapters 70 to 75, in which chapter 70 is about the general infective syndromes of CNS, 71 being about the bacterial meningitis, 72 about tetanus, 73 about viral meningitis and myelitis, 74 about viral encephalitis, encephalopathy, arboviral encephalitis, Nipah virus, and in 75th chapter we will be discussing about the parasitic and fungal infections of the central nervous system. Okay, so let's just start with the very first chapter, which is chapter 70 about the infective syndromes of the central nervous system. In this chapter, we will be previewing in brief what is meningitis, what is encephalitis, encephalopathy, and what are the various space occupying lesions in the central nervous system. तो सबसे पहले हम एक ओवरव्यू ले लेते हैं कि CNS infections are quite significant causes of morbidity and mortality, and most CNS infections are medical emergencies that require prompt diagnosis and treatment. Now, the anatomy of CNS. The CNS includes the brain and the spinal cord, both enclosed within three layers of meninges: dura mater, which is the outermost layer, arachnoid matter, which is the middle layer, and pia mater, which is the innermost layer. The arachnoid and pia mater combinedly are known as leptomeninges, and the space around the meninges is known as outside the dura is the epidural space, below the dura is the subdural space, and below the arachnoid is the subarachnoid space. Now this pia mater is very closely attached to the brain parenchyma, so there is no space but no potential space between the brain and the pia mater. So what are the main infective syndromes of CNS? There can be meningitis, there can be encephalitis and encephalopathy, and there can be some space occupying lesions, while other syndromes may also be there in CNS. So the first agents of bacterial agents of meningitis, the bacterial agents primarily cause meningitis. They may also cause brain abscess, CSF shunt infections, and neurotoxin mediated diseases like tetanus. The viral agents mainly cause meningitis and encephalitis. The parasitic agents commonly cause space occupying lesions and encephalitis. These rarely cause meningitis, and the fungal agents are primary causes of meningitis in immunocompromised people. Okay, now the routes of CNS infection, there can be hematogenous spread, which is the most common route in which the pathogen enters through the choroid plexus or brain blood vessels. There can be direct spread from adjacent infections, example otitis media, mastoiditis, sinusitis. There can be anatomical defects like surgery, trauma, congenital defects that allow the entry of organisms, and there can be direct intraneural spread, which is least common. It is seen with rabies or herpes simplex virus. Now, meningitis. Meningitis is the inflammation of the leptomeninges, which are the arachnoid and the pia mater. It involves the subarachnoid space. Classification by onset. The meningitis can be classified as acute or chronic. Rapid progression of meningitis within hours to days is known as acute meningitis, and it is subdivided into acute bacterial or pyogenic meningitis and acute viral meningitis. Other than this, there can be chronic meningitis which persists or worsens over more than 4 weeks and may have a subacute course of several days. Now the host response. एक्यूट बैक्टीरियल मेनिंजाइटिस के अंदर हम लोग याद रखेंगे CSF shows increased neutrophils, polymorphonuclear cells, while in viral and chronic meningitis CSF is mostly lymphocytic. Exceptions exist to these patterns, but in general this is the case. Now the types of meningitis. Acute bacterial pyogenic meningitis characterized by neutrophilic PMN response in CSF. Exception is Listeria monocytogenes, which causes lymphocytic CSF. The common pathogens are Streptococcus pneumoniae, which is the most common overall pathogen. Neisseria meningitidis, group B streptococcus, Haemophilus influenzae, Listeria monocytogenes, and the gram-negative bacilli like E. coli. Now, about acute viral meningitis, more than 85% cases caused by enteroviruses. Other agents are herpes virus, arbovirus, HIV, mumps, and LCM virus. CSF findings are predominantly lymphocytic, can have both acute and chronic presentation. Now, chronic meningitis is defined by symptoms and inflammatory CSF lasting for more than 4 weeks. There can be non infectious causes like malignancy, autoimmune diseases, chemical meningitis. Now, clinical forms can present as chronic persistent, which have constant symptoms, chronic recurrent, which have intermittent symptoms with normal CSF in between, like Mollaret's meningitis. And CSF is usually lymphocytic, but neutrophils may also be present here and there in some cases. Now, the etiologic agents of chronic meningitis, of course, there will be bacterial causes mostly. Partially treated bacterial meningitis can present as chronic meningitis. Parameningeal infections like otitis media can lead to chronic meningitis. Mycobacterium tuberculosis infection can lead to pyogenic or the chronic meningitis. And Borrelia burgdorferi, the Lyme disease, and Treponema pallidum, syphilis, all these can lead to chronic meningitis. The rare causes are nocardia, actinomyces, Trophema vipili, Leptospira, and Brucella. Now, the viral causes are mumps virus, ecovirus, herpes virus, HIV, and lymphocytic choriomeningitis virus. The parasitic causes of chronic meningitis are Toxoplasma gondii, free-living amoeba, Trypanosoma brucei, which is the African trypanosomiasis, Angiostrongylus cantonis, which is causes eosinophilic meningitis, Gnathostoma spinigrum, and Balisaccharis procyonis, and Toxocara canis, and Trichinella cysticercosis, schistosomiasis, echinococcus, all these cause parasitic meningitis. Now, the fungal causes are the common fungi, which are Cryptococcus neoformis, Candida albicans, Blastomyces dermatitis, Histoplasma capsulatum, Coccidioides immitis, Aspergillus species, Sporothrix kenchi, Sudaleschieria boydii, and Cladophialophora bantiana. Okay, some very French names. Now, coming on to the aseptic meningitis, traditionally referred to as meningitis with no identifiable bacterial cause, often includes viral, fungal, or chronic infections. Okay. With modern diagnosis, PCR, most etiologies can now be identified. The term is still used in clinical practice, but slowly becoming obsolete. Now, what are the clinical manifestations of meningitis? As we will see in the coming 2 chapters, there is high-grade fever, vomiting, neck rigidity, headache, and positive Kernig's and Brudzinski signs in meningitis. Okay, now coming on to second topic. This also we will be covering in great detail, but slight introduction to it. Encephalitis and encephalopathy. Encephalitis refers to acute inflammation of brain parenchyma due to invasion by infectious agents, most commonly viruses. Clinical manifestations: altered level of consciousness is there, behavioral changes are there, seizures, focal neurological deficits, extrapyramidal signs like involuntary movements. All these can be seen when the parenchyma of the brain is inflamed. Etiological agents include viruses like rabies, herpes simplex virus, arboviruses like Japanese encephalitis virus, West Nile virus, and parasites include Toxoplasma gondii and Naegleria fowleri. Naegleria fowleri is the brain-eating bacteria, protozoan, which enters through the nose when the person swims in some contaminated water. So most commonly that is the history. Now, CSF finding shows lymphocytic infiltrate but not neutrophilic, and frequently associated with meningitis termed as meningoencephalitis. Example: primary amoebic meningoencephalitis caused by Naegleria fowleri. Now, what is encephalopathy? Encephalopathy is the diffuse brain dysfunction altering brain function or structure, usually of non-infectious etiology. Encephalitis is infectious, infection of the brain parenchyma, while encephalopathy is diffuse brain dysfunction of non-infectious etiology, Occasionally, it can be infectious as well. Now, in infectious cases are rare due to slow virus diseases or prions or cerebral malaria, while non-infectious causes can be metabolic causes like hepatic, uremic, kernicterus is there, deposition of urea, brain tumors, toxic causes, and clinical feature is that altered mental state of the person is there. Other features are memory loss, personality changes, inability to concentrate, lethargy, progressive loss of consciousness. Diagnosis includes CSF examination, neuroimaging, and electroencephalography. What is acute encephalitis syndrome? AES is a public health concern primarily affecting children and young adults, present as acute onset fever with altered mental status like confusion, delirium, coma, and or new onset seizures. Now, हाई फीवर स्पेशली इन चिल्ड्रन इज ऑफ प्राइम कंसर्न. हमें बहुत जल्दी उसे नॉर्मलाइज करना होता है. हम लोग बड़ों की तरह उनको ये नहीं बोल सकते कि फीवर है अपने आप सबसाइड हो जाएगा. वाई? बिकॉज इट कैन लीड टू सीजर्स विच वर नॉट प्रेजेंट इन एन इंडिविजुअल, और उसे वो एपिलेप्टिक बना सकता है. What are the etiological agents for AES? Viruses are the most common, include Japanese encephalitis virus, major agent in India, herpes simplex virus, WNV, Chandipura virus, mumps, measles, dengue, parvovirus B4, enterovirus, EBV, influenza A, Nipah, and Zika. All these can lead to acute encephalitis syndrome. Now, some bacteria like Orientia susugamushi, which causes scrub typhus, and Streptococcus pneumoniae can also lead to this. And other agents are the cases linked to lychee consumption, notably in undernourished children in Muzaffarpur, Bihar. This has also been noted that such children were prone to have seizures when they suffer from fever. Now, what is the surveillance for AES? It is conducted by NVBDCP, National Vector-Borne Disease Control Program, through sentinel sites with focus on JEV and other causes. According to 2018 data, 10,485 AES cases were there with 632 deaths, almost 6% mortality, mainly from northeastern and northern states. That is where we give the Japanese encephalitis virus vaccine as a part of national immunization schedule. It's not given all over India, it's given in endemic areas. So this completes our portion of encephalopathy, encephalitis, and acute encephalitis syndrome. Now, space occupying lesions of the CNS. There can be focal CNS lesions like brain abscess. It's a life-threatening localized collection of pus in brain parenchyma. The sources can be contiguous infection like sinusitis, otitis, mastoiditis. We know always inner ear or middle ear infections can proceed to brain and cause all these brain abscess or meningitis as well. A trauma or post-surgery inoculation can lead to brain abscess, and cryptogenic or from unknown source can also be there. The common locations are frontotemporal, frontoparietal, parietal, cerebellar, and occipital lobes. Complication may rupture into subarachnoid space, which can lead to severe meningitis. What is the causative organism? In immunocompetent host, organisms like Streptococcus, especially Streptococcus agniosus, anaerobes like bacteroids, Fusobacterium, Enterobacteriaceae family members like E. coli, Klebsiella, and Staph aureus in post-trauma or surgery patients can cause all this. And in immunocompromised patients, Nocardia, Toxoplasma gondii, Aspergillus, Candida, Cryptococcus, all these parasites and fungus, and Taenia solium can cause neurocysticercosis, and Mycobacterium tuberculosis can cause tuberculoma. All these can lead to brain abscess. What will be the clinical features? There will be fever, unilateral headache, focal neurological deficit, like wherever there is that abscess, उस area के functions hamper होंगे. May also have seizures, altered mental status, and papilledema. The diagnosis is by MRI or CT. The aspirate is sent for microscopy. Culture is done for aerobic, anaerobic, fungal, and mycobacterial causes. Histopathology, serology, PCR, blood cultures positive in 10% of the cases. CSF is not much useful. LP contraindicated due to herniation risk. Okay, we do not do lumbar puncture due to the risk of herniation of the brain or the spinal cord. Now, treatment is surgical drainage. with prolonged antibiotics for 6 to 8 weeks, and empirical treatment is by ceftriaxone and metronidazole. Now, subdural empyema is the collection of pus between dura and arachnoid matter, mostly in the frontal lobe. The causes, agents, and symptoms are similar to the brain abscess. What's the difference? Brain abscess can occur anywhere, and subdural empyema is a specific name for pus between dura and arachnoid matter, which mostly in the frontal lobe. Next up is the epidural abscess, abscess outside the dura mater, intracranial abscess between the skull and the dura caused by upper respiratory flora, post sinusitis, or nosocomial agents, post craniotomy. Nosocomial agents are the agents which we acquire from the hospital. If somebody's head has been opened, craniotomy has been done, then there are high chances that any hospital acquired infection can cause this epidural abscess. Symptoms are fever, headache, nausea, and lethargy. Spinal causes can be staph aureus is the most common and present with fever, spinal pain, and neurologic deficits. Now, cystic parasitic CNS diseases. Neurocystic sarcoidosis is the most important parasitic CNS infection caused by the larval form of Taenia solium. This is an MCQ question. Now, other infective syndromes of CNS, suppurative intracranial thrombophlebitis can be there. This refers to septic thrombosis of cortical veins or sinus. You know this. Cavernous sinus thrombosis is a very dreaded condition. So, किसी भी रीजन की वजह से there is a clot formation in the arteries or veins of the brain. That's what's called suppurative intracranial thrombophlebitis. It can be divided into 3 types. In cavernous sinus, secondary to infections of sinuses like sphenoid or ethmoid, and oral cavity. We know that the dangerous area of phase via the superficial and the deep veins connects to cavernous sinus. So any infection from that area or the sphenoid and ethmoid sinuses can travel to the cavernous sinus and cause cavernous sinus thrombosis. The lateral sinuses can be involved in association with mastoiditis or otitis media because they are near to the middle ear. And superior sagittal sinus is less common to involve, rare. It can be seen with bacterial meningitis. The management is by antibiotics, hydration, and surgical removal of the infective tissue or the thrombus itself. Now, there can be some CSF shunt infections. These occur in patients with ventriculoperitoneal shunt used in hydrocephalus. Organisms involved are skin flora organisms like Staphylococci, Staph aureus, Propionibacterium acnes, and other causes like Acinetobacter, Pseudomonas, Klebsiella, E. coli, Serratia, and Candida. The diagnosis is by positive cultures from shunt tip, valve, or CSF. Now, there is something called as infectious myelitis. Myelitis is the inflammation of the spinal cord. This can disrupt brain-body signal transmission. Etiology, the most common agents are viral like poliovirus and others. We know poliovirus causes lower motor neuron palsy, and there can be bacterial causes like Mycoplasma pneumoniae, Mycobacterium tuberculosis, syphilis, and brucellosis. Fungal causes like Cryptococcus, Coccidioides, Blastomyces, and Histoplasma. There can be parasitic causes like Schistosoma, Toxocara, Echinococcus, Taenia solium, Trichinella, and Plasmodium. Now, there can be at last the neurotoxin mediated infections. We'll cover this in detail in tetanus chapter. Tetanus is caused by Clostridium tetani and produces tetanus toxin which causes muscle spasm and autonomic dysfunction. Tetanus is also called as bow disease or the dhanur rog, जिसमें जो patient है, his head and feet are on the bed or floor and the whole body rises up like a semicircle, forming a bow of the dhanush band. Okay, the last one can be botulism caused by Clostridium botulinum. It's an anaerobic bacteria, potential cause of food poisoning in canned foods, and this produces botulinum toxin which causes flaccid paralysis and mainly due to food poisoning. It's there. We know botulinum toxin in diluted forms is used as anti-wrinkle agent because it causes paralysis of the area, so the muscles will be relaxed and the wrinkles will be gone, commonly known as Botox. Okay, so this completes our first introductory, the 70th chapter of the CNS unit. And now in the next chapter we'll be reviewing the agents and the causes and the pathophysiology and the treatment of bacterial meningitis. Okay, so like, share, subscribe. Thanks for watching.